So my goal today is to go over kind of the basics of stress testing in the first few slides here, kind of go over the different modalities, the pluses and minuses. And then in addition, I'm going to spend a little bit of time on the merits of exercise stress testing. We heard from someone at the VA where maybe there's a patient population that can't do so. But I want to tell you about all the information you can get from an exercise stress test. And then finally, what do we need for imaging? When do we actually need it, and what will we actually get out of it? So what we're going to do is start with what you need to know. I'd like you to remember these 4 questions every time you're considering ordering a stress test. So 1 is, what is my question? 2, is this an appropriate patient on whom I should be getting a stress test on, or should they be going home with ibuprofen for costochondritis, or should they be going straight for cath? Should I be getting an exercise, or should I be getting a pharmacologic test, and do I need imaging? So those are the 4 questions that I want you to remember every time that you order a stress test. So we'll start with a case. This is a 64-year-old woman who's hypertensive, only hypertensive, really no history of coronary artery disease. And she has chest pain that occurs at the beginning of her walk, subsides as she warms up, but she still comes into the ED, gets admitted for this chest discomfort. So before we move on, again, just take 30 seconds to talk to maybe a different neighbor to say, what type of stress test would you order? So just take 30 seconds. We won't ask you specifically what you would order, but just talk to your neighbor for 30 seconds. All right, so hopefully, as you were chatting as to which stress test you'd like to get, you were trying to figure out, well, what exactly is my question with this particular patient? We heard stress thallium, we heard about risk stratification, we heard about ETTs. Mainly it was under the theme of coronary artery disease. But remember that we can get a stress test for a variety of reasons. And just like when you order a CBC and get a white count, your question is, well, does my patient have an elevated white count that would reflect an infection? And we need to have the appropriate question for a stress test. Just to keep in mind that you can have stress tests for valvular disease, stress tests for heart rhythm disorders. Do they have an exercise-induced arrhythmia? What is their exercise tolerance in general, if we think that someone is starting an exercise program? But we're focusing on coronary artery disease, but we're going to focus even a little bit more narrowly. We're going to focus, there's many things that we could ask. In general, what we ask for patients that don't have coronary artery disease are my symptoms, the patient's symptoms in front of me now, are they due to ischemia? But you could also ask, does my patient with an NSTEMI or with unstable angina, can we risk stratify them to see if we're going to take them to cath or not? Somebody could have known CAD. We'll take the VA example again, and very sick vets who have known 3VD. Did the nitrate that I just add, did the beta blocker that I just add improve their symptoms, improve the amount of ischemia that they have? So it is important for us to know what it is. Maybe somebody's had a myocardial infarction and we want to send them to rehab. So let's go back to our patient. Our patient is someone with no known coronary artery disease, and we want to figure out a question related to coronary artery disease. And usually our question is, does this patient have coronary artery disease? More specifically, we can define that arbitrarily, but typically we can think that, is there a flow-limiting lesion that's causing those symptoms? A flow-limiting lesion we could define as something as a luminal constriction of greater than 70% that is resulting in angina. So a little bit more sophisticated question than just yes, no coronary artery disease. Does our patient have a flow-limiting lesion that's leading to angina? Okay. So we have a question, and we should always make sure we have a question, but we're going to focus on this question. So is it an appropriate patient? So the first gentleman that spoke to us was maybe stress testing a younger person. Then again, we're going to keep going back to the wealth of pathology that is the VA. And then we think of our patient. Is this an appropriate patient to stress, or are there better alternatives? So this is a graph that I like to show that maybe tells us a little bit about the utility of a stress test. So this is the pre- and post-test probability. So let's say this is the pre-test probability of having a flow-limiting coronary artery disease. And usually I like to use either, probably we'll say Dr. Roy, who's the strapping example of cardiovascular health. And every year I just have to stand him up, have him flex a little bit, or look very cardiovascularly healthy. Thanks, Chris. So as kind of the pinnacle of his physical condition, he's down here. So he comes to me and says, I'm very healthy, I've never smoked, have no family history, my cholesterol is 0, but I'm having this chest pain right before this conference starts. Probably non-cardiac. So if I did a stress test on him, then his pretest probability goes from maybe 10% to 19%, and it doesn't really help me. We'll go back to the VA, and where's our VA doctor or health practitioner? There you are. So your patients come in, they maybe are a little bit, let's say, past middle age. They've stereotypically maybe smoked, they have diabetes, and they're coming in, doc, I took a nitro coming up the stairs to see you. That's probably coronary artery disease. So if your question is this coronary artery disease? It's not going to help you because they have disease. And if you do a stress test, it's only going to tell you that, well, now instead of being 96% sure, you're 99% sure. As an aside, it's a different question if you ask, well, how much do they have or where do they have it? We're just asking, do they have it or do they not? So the ideal person is someone who's an intermediate risk, someone who possibly has some risk factors, including being in the right age range, someone who has typical symptoms, usually defined as something that will start with exertion and either go away with rest or maybe a nitroglycerin. You want that intermediate risk patient because you're going to get the most bang for your buck from the test. You're going to have a kind of a reasonably low pretest probability, but it will actually skyrocket in this intermediate risk patient. So 1, you've got your question. 2, you've got an appropriate patient. It's not someone you would have sent home for non-cardiac reasons. It's not someone you probably would have gone straight to cath. It's someone where there's a little bit of question.